Mental Health America. Mental Health America is represented by Emily Scahill, and she's going to tell you a little bit about themselves.
Hi, everyone. Yeah, I'm Emily Scahill. I am the manager of public education and awareness at Mental Health America. My colleague, America Paredes, is our Associate Vice President of Partnerships, and she is also on the call today, but without internet. So to give some background on MHA, we were founded in 1909. We are a national community-based nonprofit dedicated to addressing the needs of people living with mental health conditions and really promoting mental health as a crucial part of overall general well-being for all people. In our national office, we focus a lot on awareness and public education campaigns and policies. And we have 200 affiliates across the country who do more direct services. So that's the very brief overview, and really excited to join y'all.
Thanks, Emily. I want to remind everybody that the webinar is being recorded, so just keep that in mind as we go forward. And then I have a couple of announcements to make. I wanted to take a moment to let everyone know that in the next few weeks, Grace and Pat Hines, our VP of Strategy and Initiatives, will be reaching out to members who still have unpaid 2020 dues. So look out for those. And then additionally, since the new year is fast approaching, we will begin our 2021 dues campaign, and that'll be in December. So if anyone would like to pay their dues for 2021 now, please email me at lauren@caregiving.org, and we can get the invoice sent out to you right away. Before we get started on the panel, we want to take a few moments to update you on the RAISE Council work and the upcoming National Family Caregivers Month. To do that, I'd like to introduce Mike Whitkey, who is the Senior Director of Public Policy and Advocacy here at NAC.
Unmute, Mike.
There we go. It has to happen at least once. Hi, everybody. Great to be with you today virtually. I have 3 updates regarding the RAISE Family Caregiving Advisory Council that I'm happy to share with you. First, the council has reached its 1-year mark in convening and preparing the first report they expected to submit to Congress early next year. To date, they have published a document aligning their progress towards a national strategy to support family caregivers, including a framework of the council's guiding principles and primary goals. You can find this information on the RAISE Council's webpage, which is hosted on the Administration for Community Living's website. Second, we've been working with the National Academy of State Health Policy and the RAISE Act Family Caregiver Resource Center to ensure voices of real caregivers are included in the national strategy. To do this, we have conducted nearly 30 interviews with caregivers of various ages, backgrounds, and experiences, which have been condensed into a series of vignettes and are expected to be included in that initial report. These caregivers and their stories will be amplified throughout National Family Care. Third, these caregivers and their stories will be amplified throughout National Family Caregiver Month via a social media campaign designed by our Director of Communications, Charlotte Davidson. We welcome you to share these stories with your social media networks and help lift up the voices of caregivers from around the country. Thank you for your time and attention today and for all that you do to move the needle on family caregiving policy and programs. See you next time, if not sooner.
Thank you, Mike. I also want to thank our President and CEO, Grace Whiting, for being here with us today. And I believe Grace has a few words about our new innovation groups and the topic we'll be focusing on today.
The quote this year is going to be, "You're on mute." The quote of the year. So anyways, it's wonderful to see all of you. Thank you so much for joining. If you haven't already introduced yourself in the chat box, Lauren, if you'll go to the next slide, I want to thank folks who've already participated and let you know that we've launched an innovation collaborative. So this is a working group alongside the work that we have in advocacy, the advocacy collaborative that Mike and Karen lead, and the research collaborative that Gabriella Prudencio, our Hunt Research Director, leads. So this group is focused on innovators, thought leaders, payers, providers, those who are trying to translate research to practice. And there are 3 work streams. The first is medical product development, understanding the caregiver's role in clinical trials, particularly for drugs and devices, thinking about the PDUFA reauthorization, the Cures 2.0 legislation, and also thinking about value assessment. We'll be working on a paper that will come out early next year related to value assessment frameworks and ICER. The second working group is on career pathways, thinking about how do we actually move the needle on employer protections and supports for family caregivers, particularly in the world of COVID, where we're all dealing with this in our own way. And then the third piece that we're working on is clinical pathways. We're working with a consultancy of researchers who are affiliated with Stanford and who are helping us to really understand how is it that the Medicare program and other payers support family support services, and can these payment models be used essentially to leverage more inclusion of the family caregiver in healthcare delivery models. If you're not already engaged and you want to be engaged in any of this, I would say shoot Lauren an email at lauren@caregiving.org. The other thing I'll just say, and I want the speakers to really speak for themselves, and I don't want to put words in anybody's mouth, but just from my perspective as CEO, from our board's perspective, I am very thankful today to have this topic and to be thinking about not just health equity issues, but specific to the caregiver and the family experience. We, as an organization, put a statement out earlier this summer to commit to making sure that the work that we're doing is representative. And we're lucky in that our long partnership with AARP, Caregiving in the US, is one of the few statistically representative data samples on family caregiving, with oversamples for minority populations, including African American, Asian American, Pacific Islander, and Latino and Hispanic families, in addition to LGBT families and people who are older than 75. This is important because we know that research drives policy. And so we've taken that data set and working with great people like Kim Love and at Amgen and the National Minority Quality Forum and the Diverse Elders Coalition have commissioned a secondary analysis of this data set to look at the specific needs of diverse caregivers, with additional analyses being conducted by Dartmouth College. The second project we're working on is we're supporting the fabulous work at the John A. Hartford Foundation related to the Diverse Elders Coalition and their caregiving, ongoing caregiving work, which includes a mix of research and advocacy. So this is something that we see as a continuing conversation. It's not a one-time thing or just a webinar to do it here and now, but rather we would like to make a commitment that we continue to work to do caregiving advocacy research, to look at innovation that really is representative of the broad lived experience of America's families. So with that, I'm going to hand it back to Lauren. And again, a big thank you to all of our speakers for being here today for this conversation.
Thank you, Grace. So as Grace said, our topic today is on health equity, and on a deeper level, health equity's relationship to caregiving. We want to explore what exactly health equity is, why we need it, and what we can do to be more inclusive. We'll also look at examples of people who have done it well. To give us the framework for discussion, we've brought in a few guest speakers to jumpstart our thoughts and conversation. Steering our discussion on health equity and caregiving will be Karen Lindsay Marshall. Karen is NAC's Director of Advocacy and Engagement, and she will moderate the panel and provide a summary of policy initiatives related to health equity. Please welcome Karen.
Good afternoon, everyone. If you could just give me a thumbs up if you can hear me. Great, thank you so much. So thank you for that introduction, Lauren. In my role here at NAC as a Director of Advocacy and Engagement, I primarily work with our network of grassroots caregiving advocates, specifically through our National Caregiver Advocacy Collaborative. Although amplified by the current pandemic and developments in the social justice movement, caregiving advocates, researchers, and innovators across the country have been focused on health equity generally, and with specific attention to social determinants of health, issues of diversity, representation, and inclusion, as well as common values of fairness and supporting everyone's highest level of health. I'm also involved in an initiative by the Robert Wood Johnson Foundation. It's a collective of health justice champions. That group of champions has been engaged on these issues. And as you know from NAC's statement on the need for multicultural data for meaningful patient and family engagement, as well as the other initiatives that my colleagues mentioned, we've been engaged with these issues. And we know that you have also been engaged. So the time is ripe for us to continue these discussions together and with a caregiving focus. For purposes of today's discussion, and Lauren, could you advance to the next slide? So for purposes of today's discussion, we'll level set together using these two definitions from the World Health Organization. And let's just read them together. So equity is the absence of avoidable, unfair, or remediable differences between groups of people, whether those groups are defined socially, economically, demographically, or geographically, or by other means of stratification. Health equity, or equity in health, implies that ideally everyone should have a fair opportunity to attain their full health potential and that no one should be disadvantaged from achieving this potential. So although it's with somber acknowledgement of the realities we've collectively grappled with historically and in this moment in time in attaining that equality, we again welcome this opportunity for a discussion of new and or familiar perspectives on health equity, but in the context of supporting caregivers. And to do that, we also welcome Chiffon Wong, Debbie Harris, and David Vinson. And Chiffon, we'll come to you first. Chiffon is the Executive Director of Global Evidence and Value Development for E&D Serrano, Inc. She has interdisciplinary experience partnering with patients, providers, researchers, and community organizations, and many others to improve healthcare quality and outcomes. So Chiffon, the floor is yours to tell us more about ensuring that clinical trials and other research initiatives affect the diverse experiences of America's families.
Thank you very much, Karen. Next slide, please. It was suggested that I share some remarks on how we can ensure that as we pursue different research initiatives, that we reflect the diverse experiences of American families. Now, I could talk about patient-focused drug development, which is a topic that I talk about a lot. In my organization, I am the R&D lead for patient-focused drug development. And I could remark about how, while whenever we're discussing PFDD, we rarely talk about it from an equity lens. We never really talk about how the actual principles of PFDD, when you think about representativeness or considering the heterogeneity of effect, understanding the lived experience of patients and how disease impacts them and their caregivers, encouraging us to really make sure that we're building all that we do around patients at center rather than institutions, that we think about decentralized trials. You know, all of those do have an underlying shift towards greater inclusion. But I'm not going to talk about that today. I could also talk about topics such as workforce development or cultural competency, more resources, infrastructure, and trust. But I decided that I was going to bring a bit of my whole self to this conversation because, you know, I really love the NAC community and I wanted to take a different approach with this conversation and be a little bit provocative. So what you see in the photo here is me by day. Executive director in an R&D organization. And what you see on the other side was me last night. I am an elected legislative official in my town, and I advanced legislation last night requesting that the town would fund a dedicated position in our schools for a director of diversity, equity, and inclusion. And it was a challenging experience. I was on the floor debating this for over 2 hours last night. It's probably one of the most prolific experiences of my life. And for us to get the success that we got last night, we won, we got the vote, a very robust vote. It required a tremendous amount of collaboration, courage, education, lobbying, fortitude, crossing boundaries. And as I was going through that journey to advance equitable service delivery for the students in the town, I realized how many parallels there are to the topic that we're discussing today. So I wanted to talk a little bit about that. Next slide, please. Thank you for the congratulations in the chat. When I took a step back, I thought a lot about what are the foundational enabling components that you really need to have to drive diversity, equity, and inclusion. The graphic on the left is from the Multi-Regional Clinical Trial Center, Brigham and Williams and Harvard. I encourage you to look at the resources that they recently rolled out just last week, and I'm a big fan of the graphic that I'm showing here because it gets to accountability. And when I was advocating for why, as a district, we need to have someone to help us with this, is because we currently don't have any accountability in the district for this topic. No one owns diversity, equity, and inclusion. And so I know that as we try to do that in healthcare settings, as medical product developers, there needs to be a clear sense of accountability, and accountability is shared. So at one point in the debate last night, someone said, well, can you talk about how you all envision this role? And we tried to make it clear this is this more senior level title. It's a central office position, but that there's going to be more accountability, and this person is going to have to work with other people who now I think the town realizes have been a little derelict of duty. And so these conversations can be very difficult conversations. These are not feel-good conversations. For us to make progress, we really have to look at ourselves and see where we are, see where our institutions are. And so that requires a lot of courage. To do this work, we have to have leadership. And that's why we really wanted to have this director. There were some people advocating, well, can we have the guidance counselors do it? Can the teachers do it? What if we hire a consultant? Let's hire some consultants, throw some consultants at it. And we said, no. For us to make meaningful systemic change, we need to have the right senior level expertise to bring to bear with a lot of credibility to help lead across the organization. The schools have an equity committee that I'm also a member of, and we would expect that person to lead the equity committee in any more micro level commitments that are being made at the school level. We've been advocating for audits and review, and we think that's really important. If you're trying to drive greater inclusion, there does need to be a systematic way of auditing what is already happening. And you will often find that there may be very limited data to do that. Then you need to think about remediation strategies. There's nothing like realizing there's a problem, but really not tackling how you're going to begin remediating it. And then implementing appropriate protocols and practices. So for example, from the time that the community became aware that I was going to spearhead getting this money for the schools, I began receiving dozens of unsolicited and very troubling reports for what had been happening. Now, I knew a lot had been happening. My household had also experienced some things. But what was clear was that a lot of these things were not being addressed. And they were recurring, and they were long-term in duration. And if you would ask the schools, well, tell me how many incidents happened last year and what you did when it happened. There was no incident response plan. So there was no tracking of the incidences. There was no monitoring of them. There was no shared communication about how do we respond to the individuals abroad and the broader community. So we need to really have protocols and practices, because that's how we're going to really pull this into our systems, and also start to drive some of that behavioral change. And then there's an extensive need for training. Extensive need for training for everyone involved. We talk about training, not just for students, for educators. We've even been advocating for the school committee members. They should undergo some training. And then community communication and engagement. We need to make sure that as we're trying to outreach different communities, we need to have really strong internal communication plans and also external communication plans. And those can't be one directional. It can't just be about I share information one way. It really has to be a partnership where you seek to also partner with credible organizations who have roots in the community with the people whom you're trying to work with. Next slide. I also want to talk just a little bit about the application of different analytical frameworks. I've had a couple of observations recently as I see the topic being talked about more and more. I don't usually see a lot of analytical underpinnings. So I'm sharing one reference here. It's a reference from Victor Ray, and it talks about a theory of racialized organizations. I think for us to do this work successfully, we're going to have to be more expansive in our thinking about the different types of expertise and lenses that we use to get this work done. So for me, my background training is in behavioral psychology and psychopharmacology. And then I also have master's level training in epidemiology with a focus on social epidemiology, social determinants of health, built environment, health disparities, and then health services research training in quality and outcomes. I've noticed that in many spaces, we don't have enough people with social social science lenses in this space. And I think it's a big gap. I think it's a gap. And so I think we need to think more about the composition of our multidisciplinary teams to make sure we have the right skill sets to help us think through things in structured ways. So for example, people talk a lot about racism. And they say racism as if it's like one thing that operates in one way. And it's important that when you talk about something such as racism, what is the level of analysis? Because there are micro, meso, and macro approaches to that. And then that addresses what the features look like and how it shows up and what the conflicts might be. And so I wanted to just share this quote from the manuscript, and you'll see I have the hyperlinks in the slides. You can click and learn more if you'd like to. It states here, racialized theory must account for how both state policy and individual attitudes are filtered through and changed by organizations. Seeing race as constitutive of organizations helps us better understand the formation and everyday functioning of organizations. Incorporating organizations into a structural theory of racial inequality can help us better understand stability, change, and the institutionalization of racial inequity. So the thing we have to realize is here, these are systems and structures, and there are interdependencies between them. And it's really important as we think about, well, how do we become more inclusive, and how do we change our own patterns, that we really take the right level of analysis and apply some pretty robust analytic frameworks to help us think through what's operated here and to understand what we want to look at. I don't know if any of you had the opportunity to catch this recent, really powerful article that was in ProPublica. It's a long read. LinkedIn says it's a 30-minute read. It was pretty long. It's worth every moment of it. It's called Sent Home to Die. And I'll read a quote from it. In that moment, Ochsner made a decision in stark contrast to those made by other hospitals in COVID-19 hotspots across the country. At a time when relatives were being kept away from their sick loved ones to prevent the spread of a contagious and deadly virus, Ochsner sent infected patients back into communities to die at home and to be cared for by untrained family members without the proper protective equipment. The interviews revealed a striking pattern. Before they died, about 24 patients first sought care at a hospital, which then discharged them, in many cases, sending them back home to die with hospice care. All were Black. As capacity shrunk, Ochsner employees adopted an unusual method to withhold life-sustaining care from patients with poor prognoses, several told ProPublica. It's a very difficult read, but it's an important read for us. It's a really important read. I encourage everyone to read this article. Next slide. And so I conclude with a question. And I ask this question because I've been in many situations where people are talking about clinical trial diversity, for example, and how can we do better outreach? And often in that conversation, I'm the only Black person in the room. So I'd ask you, and I ask you to ask others as they talk about this topic of inclusion, how diverse, how equitable, and how inclusive is your own organization? That's an essential question to start with. Thank you for the time and for the invitation to share some conversation with you today.
Thank you so much, Chiffon, for bringing your whole self and sharing that with us, and for also posing this question. And I'll leave it up here for just a second so you can make note of it and we can come back to it. Lauren, whenever you're ready, could you go to the next slide?
Can we
So, hello?
now, or should we wait to the end? I'm sorry, this is Kathy.
Oh, sorry.
Okay.
So Kathy, if you want to, we'll have an open discussion at the end, but as you're thinking about these things, I would encourage folks to also chime in the chat box, because that will help us come back to those comments and ideas and insights.
Thank you, Grace, for suggesting that. So next we'll move to David Vincent. Welcome, David. David is the Chief Program Officer with SAGE, where he provides vision, oversight, and leadership to all direct service programs at SAGE, including care management, housing, and behavioral health, among others. So David, please share your insights on what we should consider when it comes to programs and services for people who identify as LGBTQ and the friends and families who care for someone who identifies as LGBTQ.
Thank you so much, Karen. First of all, thank you to the National Alliance for Caregiving for inviting me. Thank you, Grace and Lauren and Karen, for facilitating this important conversation. And thank you, Siobhan, for really kicking us off. For those of you that aren't familiar with SAGE, SAGE is the country's largest and oldest organization dedicated to improving the lives of LGBT, lesbian, gay, bisexual, and transgender older people. We were founded in 1978 and headquartered in New York City. SAGE is a national organization that offers supportive services and consumer resources to LGBT older people and their caregivers. SAGE operates a citywide caregiving program targeting LGBT caregivers with the support from the Department of Aging in New York City. SAGE also advocates for public policy changes that address the needs of LGBT elders, provides education and technical assistance to aging providers and LGBT community organizations through its National Resource Center on LGBT aging, and provides cultural competency training through SAGE Care. We have staff located throughout the country, and SAGE also coordinates SageNet, which is a growing network of 30 affiliates throughout the country. Excuse me. So, what do we know about LGBT older adults? The estimate is that by the end of 2020, there will be approximately 7 million LGBT older adults in the United States. We know that there are significant physical, mental, and mental health disparities that affect LGBT older adults: depression, alcohol, tobacco use, greater risk for HIV, cardiovascular, and obesity. Additionally, LGBT older adults face financial insecurity. This means that they are less likely to be financially ready for retirement and have long-term care insurance. Many LGBT older adults are at high risk of living in isolation. And what does this mean? This means they're half as likely to be partnered, they're twice as likely to live alone, and four times as likely as heterosexual counterparts to be childless. So what does this mean for caregiving? We know that many LGBT older adults lack traditional caregiving support. They're less likely to have kids. They may be estranged from their families of origin. And those of you who do this work know very well that these are the very individuals who often provide caregiving services. Many, unfortunately, are living in secrecy. For providers, they may be in your practice or in your skilled nursing facility, but may not be out. They may remain closeted and have significant privacy concerns, both in your facility as well as in home. Horrifically, some go back in the closet as they age due to feelings of vulnerability. The fear is great for many, and the prospect of long-term care can be terrifying, especially for our transgender older adults. When we look at the data on how older LGBT adults access care, we know that they are 5 times less likely to access senior services. In spite of that, though, maybe it is because of that, LGBT people become caregivers at a higher rate compared to heterosexual individuals. So LGBT competent services, what do they look like? There's been a history of discrimination that leaves behind many LGBT older adults. And consequently, they have a general distrust in mainstream institutions. It's important to know that caregivers oftentimes stay away from these systems that are there to support them. This means not getting help for themselves. This leaves them at an increased risk of physical and mental health issues. Unfortunately, as they stay away, so do the ones that they're caring for. And this means less access for them in the systems and services that are meant to support them. And unfortunately, this puts those folks at greater risk of premature institutionalization. This all being said, there are things that providers can do. So providers need to continue to be open-minded about the types of caregiving relationships: husbands, wives, exes, friends, neighbors. Sometimes it can be a case manager who now they refer to as part of their family. Providers need to ask open-ended questions to the LGBT person who's receiving care. Who do you rely on for care? Who do you consider family? Who would you call in the case of an emergency? Providers do have a tremendous opportunity, and some would say an ethical obligation, to advocate for the caregiver's role as caregiver, regardless of how they define that relationship. With your LGBT patients and caregivers, ensure that they have advanced directives in place. This will avoid many issues and confusions later on as they receive care. And when you have opportunities, which everyone, hopefully everyone of us does, make your agency group and setting welcoming for LGBT people. Thank you.
Thank you so much, David, for sharing these perspectives and specific actions that we can take, and including caregivers. So next we will move to Debbie Harris. Thank you for advancing the slide, Warren. Debbie Harris joins us to share her family caregiving experience. Her son, Josh, had a grade 4 brain hemorrhage at birth and was for a time the sickest baby in the neonatal intensive care unit. Today, in addition to caring for Josh, managing her family, and an ICU-level nursing staff in her home, Debbie is a director-elect for the incoming board of the ARC-US, a family systems navigation specialist with Family Voices of Minnesota, and serves as a public policy advocate on several platforms in her local community and beyond. And as Mike mentioned, in our upcoming project where we're going to be sharing caregiver testimonials in aid of the Raised Family Caregiver Councils, where Debbie has been contributing to that. So we've been very honored to be able to work with her. Debbie, thank you so much for joining us to share your family story.
Thank you. Thank you for inviting me as well. Thank you, everyone, for just being willing to listen to our story. I'd like to approach our particular journey and apply it to notions of equity or inequity from a number of different perspectives. And first, just to tell you a little bit about Joshua and his birth and my pregnancy. And I know that many of you have, just in your fields, have heard about the statistics regarding African-American women and birth and pregnancy morbidity and mortality. And that's a topic that that is very lively today. And even though Josh is 27, it's one that wasn't really brought up that many years ago. But Joshua actually, my pregnancy was actually going well. And at some point it changed pretty drastically. And I knew that something was wrong and asked my physician if I could have an ultrasound because there had been a dramatic change in his movement and so forth. But at the time, my provider had said we'd already had one ultrasound, and that's what typically the insurance provider allowed, so we wouldn't do another, even though his movement had really subsided. And so we went along in the journey, and at one point, I began to, and I'm sorry, I'm going to probably get a little bit graphic here, but to tell you our real story, began to throw up blood and to get really weak and to just advance in the pregnancy very early. And so when I called to get medical attention, our provider group was away at a holiday party. And so the physician who was on call said to me, if the mom says something is wrong, then I believe that. And so I want you to come in right away. So he did a bi-level ultrasound at that time and ascertained that, yes, something was really dangerously wrong. And it looked like when Josh he was initially breached, and when he had turned, the cord had he got entangled in the cord. And so he hurriedly got someone from Mayo to come and do emergency surgery. They had everything set up to do the emergency surgery, but then our providers came in from the holiday party late that night. They excused that particular physician. They had the perinatologist leave, and because it was the weekend, they said we would simply wait until Monday when more departments were open in the hospital. The very next day, on Sunday, Josh went into distress. That distress was overlooked because the nurse who had been assigned to me had left my bedside for a couple of hours to just chat with a friend. And so the monitoring tape had just assembled just all over the floor. When the physician came in and saw it, she knew that we were in danger. And so it turned out that Joshua had gone into distress. We had to have emergency surgery, and it turned out that neurology said that Josh had suffered his brain hemorrhage in utero while we were in the hospital. So that began our journey, and so that's how this all started. And so when we talk about family-physician relationships and corroboration and collaboration, and the notion that this needs to be partnership, that's why, because we can save dollars, we can save lives, and we can just foster experiences for people that preclude so much suffering. Now, when I say that, I'm also acknowledging that I wouldn't change this journey now because we've learned so much and our lives are filled with joy at this point, but it hasn't been easy and it's taken a long time to get here. So that's the first area of inequity. The second I want to talk about is if you just kind of look at the slides while I'm talking. So if you go to the next slide, I want to talk about the inequity when we are trying to care for people with disabilities, and especially severe disabilities in a medical world where we're accustomed to fixing people. So when we think about allopathic medicine, we want to just kind of get people back to normality as we think of normality in an ableist culture. And so one of the problems was that as they approached Josh's care when he was born, because they knew that he would have severe disabilities, they approached our family as it's just not worth it. And so if you look at the next slide, there were instances, of course, when Josh ran into a lot of issues as premature infants do. Josh was born at 31.8 weeks. I give myself that 31.8 weeks because that is exactly the number. At one point, he had an extremely virulent shunt infection, and we went to the ED, and the neurosurgeon refused to come to do anything about that infection. And he said to me over the phone, you should go to an institution and look at some of these kids with watermelon heads and see how they come out. And he just felt like we should just take Josh home and let him die because he would be a freak of nature. So the photo you're looking at here is Josh. And actually that's not even when he was in ICU. I think he was in transitional care at that time, and he's a lot bigger than he was when he was born. And those are some of the older Minnesota Vikings. So I think they're senior citizen Minnesota Vikings now. But they criticized us for just, going with the flow with Josh. We didn't do anything heroic. We just supported what we felt like Josh was telling us and gave him the care that that seemed reasonable to do at the time. And what we were told by a social worker at the time was, I've heard the scuttlebutt in the hospital, and people do not agree with your caring for Josh the way that you do. So it's really difficult as a parent to continue to care for your child in an ethical way and in a way where parents just naturally love their children, and to have that kind of pushback as you're beginning a journey like this. And can you go to the next slide, please? So I talked about that a little bit already, and I want to attribute the slide to the Governor's Council, Minnesota Governor's Council on Disability. This is a publication that they put out some years ago when our sons were actually quite a bit younger. And so what we decided to do actually was to normalize life as much as possible for all of our sons, and to just follow our hearts and to follow what we knew Josh was telling us, and just simply to do the best we could as a family. And so Josh's prognosis was that he would live for only 2 months. And before we left the hospital, they said, never mind, we take that back. He will live for only 2 weeks. And when you take him home, you'd better call the coroner so that when he dies at home, they don't think that you killed him. So we did not get the encouragement that families need to take on such a journey that is so intense, and there's so much learning that you have to do, and there's so much advocacy. However, we did have the support and encouragement of a couple of physicians who took our side, who knew our family, and who taught us everything that we needed to know to be the right advocates for our son. And this is Josh's ventilator and his supporting equipment that you see in the picture. Next slide, please. So when Joshua actually went to school, we had to fight for him to actually be there. He needed nursing services in the school to support him while he was there, just to keep him safe. And the school district said that we could not have him in the school without providing our own nurse, one-to-one nurse, and paying for that ourselves. So we had to embark upon another journey, and that was to allow him a free and appropriate education so that he could be in the least restrictive environment with his peers. So we did that as well. And so when you think about caregivers, it's not just the medical care. It's not just what you see in the hospital. There's so much to it. It's a very detailed, complex scenario, and so we had to fight that battle as well, and get legal disability services involved, until finally the district relented and had to let all families in our district know finally that children with tracheostomies were allowed in the school, and the district would support them by providing nursing care for them as well. Josh had actually a very successful journey in our school districts here in Minnesota. He was integrated with his age-appropriate peers, and he is still very well known by people in our community. So the other thing too I'd like to say is, while we are a very small population of families of children and youth with complex medical needs, it's a different population as far as support, in that it's a long time. So it's not like a severe illness that ends in 6 months, or you know, and I'm not making light of any of the illnesses either, but Josh is now 27 years old. This photo is probably from a couple weeks ago that you see on the left with his nurse Mary. And so it's a long journey, and caregivers, families need support. There are a lot of morbidities that occur just within the family, just mental health and physical health, because it's a very difficult journey. And so 27 years of caregiving is different than 6 months, or when you're caring for an elderly parent. And so it's a long time. And for Josh, it's 24 hours. He cannot be left alone. He needs awake care and interventions and treatments and medications for 24 hours a day. And it's nursing level care. And so 24 hours a day for 27 years, it's a long time. And so we do need supports. For example, we need people to have knowledge of what we do. And so home care nursing is another thing where there are inequities, especially when the reimbursement rates are so non-competitive, as you know, in home care as opposed to hospitals. And then families who have to rely upon medical assistance rates, for example, and those who have private insurance, agencies often are more hungry for those cases that have the higher reimbursement rates than the MA rates. Or families who live in areas that are less desirable for nursing staff, they don't get staffed. And so those families are not as successful, and their children often get placed outside of the home. And so we need to do something to find incentive to make for competitive wages for nurses for families in urban areas, so that it's more fair and those families can be just as successful as families that have more means. And then also we have to consider that as you're going through this journey through 27 years, you also end up becoming a caregiver for your elderly parents and other family members who become ill. And while I was doing some research for this story, I found a text that I had written to my pastor's wife, and she'd asked how we were doing. And the text said something about, it was about my sister-in-law who was very young. She was in her 50s. And she had been a flight attendant for about 29 years. And she'd just been diagnosed with a glioblastoma brain tumor. And she had 2 young daughters, my nieces. And my brother, her husband, has MS. And so in the text, I was picking up my brother to take him to the hospital because my sister-in-law was scheduled for surgery for her glioblastoma. And at the time, our oldest son had a very high fever, so he was extremely sick. And Joshua had cerebral spinal fluid leaking out of his gastrostomy tube and was being scheduled for surgery because he had a fistula, they thought. And so I was thinking, that's a lot of things at one time, and we don't know what people's stories are. And so sometimes when we have to fight what people might consider small battles about maybe medications or paying for medications or equipment. And you can see some of the things that Josh has there. And we've had to fight for every single piece of medication and tubing and nursing and everything that you see, even parts of his wheelchair. There's so much that you have to advocate for all of the time, and it doesn't stop. And so I think just sharing our stories, and that's why I focus on narrative medicine, makes people aware and makes them more empathetic, and then helps them to develop strategies that are kinder to families so that we can get through this journey a little bit easier. I'm sorry for taking so much time, but thank you for listening.
Oh, no apologies at all. Thank you so much for sharing your story with us, Debbie.
Oh, and that's our Minnesota fall. I wanted to say that too.
Beautiful family and beautiful foliage. Thank you so much. So we'll go right into our group discussion. And I think that you can skip these slides, Lauren, maybe we'll come back to them later. But Debbie, your comments are the perfect segue. In having health equity discussions, I often tell people, I ask people to imagine that they're a caregiver of any background in a healthcare system where you don't necessarily have a recognized role. Your voice likely needs some type of amplification to reach those who make the decisions and those who provide the information and the resources. And thanks to you sharing your story, we don't have to imagine that, because your use of narrative medicine, your willingness to share your story gives us an example that we can draw from to not only imagine how inequitable the healthcare system and other systems of care can be for caregivers of any background, but how much more so how those inequities are amplified when, in addition to not having a formal role, you come from a background or an experience that's not adequately represented by data, or is subject to implicit biases or some other indicator of inequity. So Debbie, my question for you would be, as an advocate, and you've been an advocate on many platforms, what supports were necessary to help you be able to share your story, your deeply personal story, in an impactful way? You've worked with a number of organizations. What types of resources and supports have they given you in order to share that story?
I think for me, parent-to-parent mentoring. I know that there are a lot of programs out there or organizations, you know, to support us, but I think the most helpful, and I know we have to sift through a lot of information, I'm sorry, but I'm part of Family Voices of Minnesota, but prior to that becoming kind of a formal organization in Minnesota, the person who kind of leads it now really mentored me more informally and got me involved in a lot of more like advocacy and volunteering. I volunteered a lot, for one thing, to learn how to be an advocate and to learn the systems in, you know, that we depended on, so I could learn how to navigate those systems and best become an advocate for my son. And so in doing that, and then connecting with other parents who were doing it as well, that's how I learned. And so I would say mentoring programs, family to family, parent to parent organizations.
Thank you, Debbie. And I see in the chat that there are several people echoing the thank yous for sharing your story to you and all the other panelists. And Grace has reminded people that if you can raise questions in the chat box, and also you can raise your hand using the Zoom platform. And I'll ask my colleagues to help me make sure that I recognize people if they do raise their hands. But while you're thinking, perhaps in the meantime, we can go back to the question that Chiffon posed to us. And I'll thank you, Lauren. I think you're moving to Chiffon's slide. But the question was, how diverse, equitable, and inclusive is your organization? Would anyone like to chime in and share what you're doing?
Sharon, if I know Kathy Jackson had a question, you know what? So Kathy, I don't know if you want to, not to put you on the spot.
Thanks for catching that, Grace.
Yeah, no, you never put me on the spot. Thank you. It's always a pleasure to talk to all the advocates. Oh my gosh, I'm overwhelmed. I'm just overwhelmed with all the stories, you know, and I'm a nurse by background. So it just pains me to think I could have been part of that, or I could, if I didn't see it, you know, while it's happening. And I think we're just so much more aware of it. And I said, thank you so much. But my question really is for all the speakers. You know, I'm in the pharmaceutical industry, and we look at ways to diversity in terms of who you know, what we're doing, our own staffing and things. But what do you think the industry can do? You know, I'd love to get some thoughts on how can we do it better. You know, I know one piece is the representation of our own employees. You know, sometimes I look at some of the executive committees of all these companies and they're not very diverse. And I don't know how to get more people, more diversity in there. I don't know whether it's not an interest or if it's just too hard to get into this industry. Anyway, I'm so open to ideas and sending them up to our HR people, or, you know, even talking within. So I would love to kind of open the floor up for that.
Grace, this is Eve Dreyer. May I respond?
Yeah, go for it.
Okay, because I need to hang up in a few minutes, but I just wanted to share, and Grace and NAC has been very involved in this initiative. We've been working together over the past 6 months on an initiative called the Rare Disease Diversity Coalition. And our focus is on rare disease, but you know, we're happy to hear from those who even aren't involved in rare disease, because a lot of what we're doing, and we'll be presenting it in another 6 weeks, we have work groups, one of which has been very significantly supported by, you know, Grace's involvement and ideas, is focusing on, you know, better addressing delays in treatment and diagnosis. But we're going to have a call to action published in the beginning of 2021, calling on various stakeholders, including payers, government, pharma and biotech companies, diversity health organizations, rare disease organizations, to do whatever they can to support, like it'll probably end up being 4 significant actions in 2021. So, I mean, it's called the Rare Disease Diversity Coalition. You can reach out to Grace and NAC about it if you want to be on a mailing list and receive any information. But we're focusing on inclusiveness in rare disease, because in rare especially, you go to a meeting and it's all Caucasian, when in certain diseases, there's an incredibly high prevalence of Black or Hispanic or Asian, depending on the disease. But there are things that are happening. This is one of them. I just wanted to share it with you, and feel free to reach out via Grace, and we'll include anyone. I mean, we started out with my company supporting it, and we're now up to 7 different companies supporting our 2021 agenda on diversity and rare disease and inclusion. Thank you.
Grace, if you'd like, I can also make a couple of remarks regarding the question.
Yeah, I think that would be great, Chiffon, if you want to weigh in.
You asked, is it hard to get into the industry? It is. And I think sometimes the social capital that people leverage to get into positions, people knowing people, and the referral system. I mean, I think the referral system that are designed, they're kind of thinking, oh, our employees will know great people to recruit. But if your employees aren't diverse, then their networks may not be so diverse, right? So some of the referral systems we have internally really probably have some perverse unintended consequences. And so I do think that we need to kind of re-envision the whole hiring process. People talk a lot about, for example, cultural fit. What is cultural fit? Does cultural fit include like a woman with red hair and dreadlocks? Does it include that, or is that, so I think so often we sometimes forget that by default, a lot of these processes are not centered around diverse population. So it really requires us to kind of step outside ourselves and be very conscious and very proactive in terms of the implicit biases that can be operating, and trying to make sure you can have culturally diverse people from those communities be on the front lines of trying to engage in those authentic cultural spaces. So for example, if you want to go to like the Abercams conference, for example, which is a great pipeline program for up and coming young diverse scientists, it's really good if you can send, a non-white employee to Abercams. It's just important to be able to do that, because when you don't, people say, well, it's interesting, you didn't have a Black employee you could send to like the Black Scientist Conference. It sends a signal that you might not have the buy-in from your own, your own employees. I think if I were to try to have to say 3 points, it's really capital. Is, are we making the investments? Are we really looking at the culture when it comes to our hiring and support of existing employees? And is there also, leadership and advancement? I have more thoughts, but we're at time, so I'll conclude there. Thank you, Grace.
So I'm just looking at Karen. I mean, I just have to say I'm so moved and also, frankly, sort of disturbed at our healthcare system, but so moved that Chiffon and David and Debbie, that you were willing to speak so openly about your experiences and really ground us in the work that we do. This is a really big conversation. It's an ongoing conversation. And so one of the things I would say is to please reach out to us as you're doing work around this issue as it relates to caregiving. And I'm looking at Karen, and I think Gabriella might be on the call as well on our research side. It's something that we're continuing to think about, that we're not just saying this is important and then walking away from it, but that we're actually not only making a commitment as an AC, but helping those in our network to think through these issues. So I would say, please keep, the lines of communication open. To the degree you're working on this around advocacy, connect with Karen and Mike, and we can, Lauren, send around some of our team contacts again. And then likewise in research, know that Gabriella is doing a lot of work around that. But I just, this has given me so much to think about, and I think is the beginning of an ongoing conversation. And Karen, you want the last
Grace,
word?
yeah, I'll just say that I think that I echo everything you just said, and I again thank all of the panelists. And I, at the risk of sounding like a cliche, I think we're at a turning point. For those of you who don't know, I was a family caregiver, and I was a family caregiver for two parents who grew up in the rural segregated South. Both of them went to segregated schools. And we could have an entire webinar on my experience trying to represent them in a healthcare system and in social care systems, which weren't necessarily built with them in mind. And even if they were, interacting with people who didn't necessarily understand the depth of their experiences and how those experiences prevented them from being able to advocate on their own behalf. So in addition to all of the challenges that caregivers face, a lot of caregivers face another layer of challenges in having to overcome historical, systematic issues and obstacles that keep them, frankly make it harder for them to advocate on behalf of their loved ones. So I just, again, echo what Grace said about this being an important conversation. The time has come, not necessarily for us to solve everything in one big swoop, because I think it'll take a lot of time to undo a lot of what's happened, but it is definitely the time to commit to having these types of conversations on a regular basis with each other and every day in our own work. So thank you again, everyone.
Okay, well, with that, we'll close out the webinar, and we'll share the recording and the slides if you have colleagues that you think might be interested. Lauren, anything else before we go?
That's all. Just thank you to the speakers and everybody who joined us. And the webinar will be up on our YouTube, and I'll send that link out when it is. It should be about a week or so.
Thank you all, and thank you again to the speakers.
Thank you so much for having us.
Thank you for the invitation.
Thank you.